Hello, I'm Peter Bovey. I'm a general surgeon and I'm here to talk to you about surgery on toenails, in particular ingrown toenails and deformed toenails. Ingrown toenails are quite common. They often occur in children and in teenagers, but sometimes in older people. Basically, an ingrown toenail is essentially a foreign body reaction to the body's own nail that's sticking into the tissue at the nail fold. Often this occurs after minor trauma. You might stub your toe, you might have your toe injured playing sport, particularly football. It might occur after a hike or a long walk. Sometimes the problem is brought on by the patient, picking or pulling bits of the nail off or cutting their nail improperly. It's important to cut your toenail straight across. If you cut it in at the corner or you cut it too short, you can end up with a nail spike under the skin at the visible edge of a nail, as per this diagram. You can be predisposed to having ingrown toenails. Often there's a family history. One of your parents or one of your brothers or sisters will have trouble with ingrown toenails. Sometimes this is because you've got very big feet, or you've got very big toes, or you've got nails that are too broad for the toe, or that are too curved. In fact, nails can become curved with time. Certainly I've noticed my own toenails are more curved than they were when I was a teenager. Often ingrown toenails will settle without surgery. Proper nail care, bathing, and sometimes antibiotics will help. By the time patients are referred to me with problems with nails, they usually need an operation. The problem will either be that the ingrown toenail won't settle down or will be recurrent. Often I'll see patients who've had previous surgical procedures done on their toes, either by general practitioners or sometimes by podiatrists. Surgical options are a number, but basically I'll only consider 3 procedures on ingrown toenails. Firstly, I may just elect to avulse a nail. This is not an unreasonable thing to do, particularly in young people, or if it's the first time that someone's had an ingrown toenail. Secondly, I might elect to do a lateral wedge resection of nail bed. This is the definitive procedure that I'll use for an ingrown toenail most often. Thirdly, there's a Zadix procedure or radical ablation of nail bed. And this is something that I would usually reserve as a last resort for an ingrown toenail, but it's often the best operation to consider for someone with a badly deformed nail. These procedures are usually done by me under a local anaesthetic in my office, what we call a digital block or a ring block, usually also with a tourniquet. These procedures can be done in hospital under a general anaesthetic, also with a tourniquet. The tourniquet is required because otherwise there's so much bleeding that you can't really see what you're doing. The different procedures, the avulsion is done with no incision. An artery forceps is put under the nail along the edge, and basically the nail is rolled off the nail bed from one side to the other. There's minimal bleeding, there's very little post-operative pain. The problem with the procedure is that when the nail regrows, it may end up ingrown again. And I think this is a very reasonable thing to do as a first procedure or in a young patient. But if someone gives a history of recurrent problems with an ingrown toenail, I don't think it's appropriate just to avulse the nail. The wedge resection of nail bed can be seen in these diagrams. It's usually an effective procedure for an ingrown toenail. I've done a literature search and have read of recurrence rates of up to 30%, but in my own hands the recurrence rate is less than 1%. The procedure involves incising and removing a slither of the nail at the edge of the nail, and below this a similar piece of nail bed. It involves sutures, both at the cuticle, and I usually also place a suture through the nail into the edge of a nail fold. The diseased tissue at the edge of a nail is also removed. The cosmetic result is usually good, and it can be done on both sides of the nail if both medial and lateral edges of a nail are ingrown. Some GPs and surgeons, instead of excising nail bed, apply phenol to it. I've never liked this, and I don't practice it. I've seen some bad results from phenolization. Occasionally one will see a recurrent ingrown toenail after a lateral wedge resection of nail bed. Usually that means that not enough has been removed for first operation, and in this situation I'll usually just do a redo lateral wedge resection of nail bed and take a little bit more nail and nail bed out. One of the advantages of this procedure is that you don't have to wait until the nail regrows. The sutures are usually left in for about 7 to 10 days. The Zadix procedure is the most radical of the operations I would consider doing on an ingrown toenail, but it is often required in a deformed nail, deformed either by chronic fungal infection or by previous trauma. With the Zadix procedure, as in this diagram and these photos, the germinal matrix of the nail bed is excised, and as a result the nail does not grow back. The nail bed that's exposed becomes thickened, and you end up with some sort of thickened skin where there was once a nail. I don't particularly like this operation. I think it leaves a rather ugly cosmetic result. And it's possible doing a Zadix to leave a tiny bit of nail bed in the corners and have nail spikes develop there, which can be a real pest. The operation, as I said, I do in my office under local anaesthetic. It's important doing a digital or ring block to test the anaesthetic has worked, because basically one is anaesthetising the digital nerves. In other words, the local anaesthetic is not put into the area that you are putting to sleep. It's put in blocking a nerve proximal to the anaesthetised area. With a normal anaesthetic, it's a field block, so the local anaesthetic is put in where you're going to cut. The field block always works if enough local is used and you wait long enough, but nerve blocks don't always work, so it's important to check before you cut the skin that the local has actually worked. After the end of the procedure and once the tourniquet is removed, these always bleed, and it usually takes 15-20 minutes for the bleeding to stop before a dressing can be applied. I normally put a toe bandage on the toe. It's quite common for patients to find once they start walking around and once they hop in the car and drive home, that they'll start to bleed on the way home. I tell them once they get home, if they rest and elevate their leg on a couple of pillows up above the level of their heart, the bleeding will stop. After about 10 days, we take the bandage off, remove the sutures, put some steri-strips on, and then the patients are able to wear normal shoes. Up until that time, it's quite common that you're unable to wear closed-toed shoes, and I tell people that they won't be able to wear normal shoes, they won't be able to wear boots to work. It's possible to have a complication from toenail surgery. The most common complication is wound infection. Often when we operate on ingrown toenails, they're infected at the time. I like to get the toe in the best possible condition before operating. That's not always possible. If the toe looks infected at the time of the surgery, I'll discharge the patient on oral antibiotics. If a post-operative infection occurs, it's usually easily treated with oral antibiotics. I've probably done well over 1,000 ingrown toenail procedures now, and I've only had one that ended up being admitted to hospital with cellulitis of the toe requiring IV antibiotics. It's very common to have some bruising. The bruising always settles within a few weeks. And as I mentioned, there's a small risk of having recurrent ingrown toenails. But in my experience, that's an uncommon problem.